All right, let's go ahead and get started. Welcome back, everyone. Um, this is our deep dive number 2 for our social health data convening series. I'm going to go ahead and just share my screen really quickly here, go through some slides before we get to the conversation. All right. So just some initial sort of housekeeping things. I know we had touched on this when we met last time a couple of weeks ago. But essentially, this session has been designed to be an open conversation centered around some key questions, though we really hope that this conversation is organic and leads in different directions based upon presenters and attendees' emerging interests and needs. Attendees are muted to prevent any background noise and disruptions. But as attendees, you do have a couple of ways to converse and bring up questions. So there is both the chat and QA functions available to folks. The chat is really used to provide comments, feedback, requests for follow-ups, and so on. And then the Q&A functionality can be used to propose specific questions to either HealthInfoNet and or our presenters. We will be keeping a parking lot of questions and topics for further discussion. I know we also touched base on this last time, really just meant to be helpful in regards to the fact that we've divvied up these conversations into some pretty key areas. So if there are things that either might be a focus of a previous deep dive or our future deep dive coming up, we may follow up about it later or save it in that parking lot for the next deep dive that we're doing. Attendees may be asked to share their organization's experiences around social health and or SOGI through some poll questions. So they're certainly optional, but we encourage you to participate in them as we are having our discussion. So let's just do a little bit of a recap of a couple of weeks ago when we were really focusing on data collection methods. I think there were a lot of really great takeaways from that conversation. The presenter organizations were all at different stages of data collection, implementation efforts, and model maturity. The presenter organizations were continuously redefining ways to collect the data based upon best practices and lessons learned internally and externally. The presenter organizations also offered different opportunities. We talked about paper forms, we talked about face-to-face and some other digital electronic means of data gathering that really allowed patients to provide their updates and information in a way that was accurate and timely. So I think that was some really great conversation that we had. One thing too that I'll mention here before we talk about this particular session is just another reminder that these presentations are being recorded and that we will be allowing access to that, to each recording at the end of our convening, along with a report of all of the findings as well. So for folks that at your organizations that may not be able to attend the session, we'll definitely have the recording available for folks once we're completed. So let's talk about today's deep dive and the folks that we have presenting here today. So our focus and purpose is to discuss how our HIE participants are storing social health and or SOGI data elements within their own internal clinical system. So the learning objectives for today are to learn how the healthcare providers are storing this information, identify if any social health and SOGI information collected is codified and standardized, and then determine if the social health SOGI information is ever made available for external exchange by the healthcare provider. So that's sort of a highlight of what we were looking to talk about and discuss today during this deep dive. So We do have our presenters here on the call, with the exception of Northern Light. So we did have a scheduling issue that had come up for Emily, so she's not able to attend today, but we do have folks from Maine General, Maine Health, NASON, PCHC, and Greater Portland Health here on the call today. So similar to how we did last deep dive, for those folks that as you start to discuss and answer some questions for us, if you just want to introduce yourself and your role at your organization, that would be super helpful today. And with that, I'm going to stop share. I do also, actually, before we jump into things, also sort of introduce Chad McLeod and Liz Klosner, who are on the HealthInfoNet team, who are the faces too that you will see up here with myself as well. And Lady Patterson, who's also on the team and on the call today from HealthInfoNet. So they are here to support us, or support me as we facilitate this conversation today. So thank you all for being on the call and talking about data collection and data storage here. So I guess to sort of jump things off, our first discussion question and what we were hoping to start with today is to confirm the data collection system that's currently being used at your organization. So I know we talked a little bit about what everybody was using for their EMR, but I think that would be a nice jumping off point here as we begin this conversation. If folks just want to go around and let us know, what is the current system that they're using at their organizations?
So, hello, I'm Marty Sable. I'm Director of NASON Healthcare, part of York County Community Action. We use the next-gen electronic medical record system and practice management and dental record system.
Sorry.
Hi, I'm Holly Glidden. I'm the EHR trainer and systems analyst for Greater Portland Health, focusing mostly on the practice management side. And we are exactly the same as NASON. So.
Great, thanks, Holly. And
I can go next. This is Matt McCann. I'm Director of IT Applications here at Maine General. We actually have a couple different EMRs. Our inpatient data is in Altera's Sunrise Clinical Manager, and our outpatient data is in TouchWorks, which we recently rolled back to over the summer. So it's a split between those two.
Great, thanks, Matt.
Hi, this is Ann Du, and I'm a clinical informatics specialist at Maine Medical Center, part of Maine Health. And we are collecting data through the Epic application, and we store it in 3 different databases for the reporting purposes, including Chronicles, Clarity, and Caboodle. So the Clarity and Caboodle help with more flexible reporting, but most of the time we're using the Clarity to kind of collect and store that data.
Okay, great. Excellent, thanks, Anne. And I know I just saw Felicia in the comments who is representing Northern Light there and mentioned Cerner. And I'm not sure if someone on the call might know who. It looks like our folks from PCHC aren't on the call yet. But I can't remember off the top of my head if we know.
I think they're Athena.
Athena. Okay. Yep. That sounds right. Thanks, Holly. Good. Okay. I just wanted to level set that. I know that we had a couple of weeks ago, so we talked obviously a lot about how folks are collecting this data, the social health data. I guess one of our questions for today's call was to really kind of think through or talk through once that information is collected and it's put into your records, into your health system record, is there a way that is vetted or moderated go by a clinician before it sort of becomes final within that record. And maybe, I guess, in particularly for those folks that might be using some sort of patient portal or patient access as a way to gather that information, that is it, once somebody enters that information, does it have to go through a particular process before it actually gets implemented and put into their record, if that makes sense to folks?
This is Jess at Nassau Healthcare. I'm the clinical information specialist here. So just to tell you about my role real quick, I'm primarily focused on the clinical side of the application. So for us, the medical assistants dispense the prepare tool, and then the providers, as part of our clinical guidelines, are the ones that review the answers.
Okay. And so that once they've reviewed that, looked at it, it enters and, becomes final in a sense and gets entered into the record.
Mm-hmm.
Okay. Great. Sense. Thank you, Jess.
Nicole, this is Wendy. I can chime in. I'm Wendy Jorgensen. I'm the Director of Population Health here at Maine General. And as we spoke in Deep Dive 1, Maine General is early in this process and still building this out. But the way we've sort of designed the workflow is that the patient would complete a paper form. The medical assistant would sort of transcribe the patient's answers into a template within the EMR. And then the clinician would be asked to sort of review any positive responses and, choose a Z code, for example, that would correspond and add that to the problem list. So there's a few different touches there.
Okay. Great. Thanks, Wendy.
This is Ann Dew with Maine Health, and we do use within our Epic system, we have smart data elements or flow sheets that can be used to collect this data. So that notes the date and the time of the information, and it's also interdisciplinary. So depending on what the screening is, the screening can be available to multiple clinicians, the nurse, the provider, whoever may be the appropriate person, social workers, for example. And then we do use governance groups to review the screenings before we have them available in our system, just to be as standard as possible and make sure it's like an evidence-based practice screening tool, or that it can flow between different care settings if it's appropriate.
Okay, great. And for those patients that might be going into My Chart online and maybe entering any information there, is there a process before that enters the record, or does somebody have to, is there a staff member that has to review that and confirm it in a way before it enters the record at all?
No, it can be entered directly into Epic, into their chart.
Okay.
In terms of workflow, I don't know the full workflow since my focus is mostly on the inpatient side, but I'm sure they would be reviewing that during their visit.
Okay.
So if it would be in their My Chart, same thing for some of the SOGI data can be collected within My Chart. It would be available immediately in their record for the clinician to review.
Okay. Great. Thanks, Ann.
Hi, this is Holly from Greater Portland Health. We're kind of doing a little bit of everything, a little bit right now, just to figure out a really good workflow. But it will be pretty similar to, we will be using the prepare tool. And it is loaded in NextGen. We're going to be using it as paper form and giving it to the patients. Then we'll have someone, for lack of a better word, transcribing the answers into the prepare tool. And then the providers will review. And the nice thing that we've been told about using the prepare tool within NextGen, depending on the answers, it will automatically fire the Z codes for the providers. So those will already be available to them.
Oh, wow.
That actually used to be the case, and they've backed away. The providers now have to they can't be prompted to a diagnosis. They need to come up with them themselves.
Really, because we were just told this very recently.
They're great. That's good news then.
Yeah, so maybe they've gone back to more like a decision support tool kind of thing. I don't know.
Yeah.
But Anne, I have a question for you for Maine Health. Did you say it's in a flow? It's in your flow chart. The result, like when the date it's done and that sort of stuff.
Yeah, we do have a combination of flow sheets and what's called smart data elements. So one of the benefits of flow sheets is that you can see like the trends over time with your reporting. So I think as we like collect more data over a patient's lifetime, that will be, helpful to see trends and things like that.
Yeah, I think that's something that we've kind of been tossing around too, like, how do you see trends and that sort of stuff. So interesting. Thank you.
Yeah.
Nicole, could I ask a question?
Yeah.
Great. And I'm kind of jumping the gun here, but I heard it brought up. So this one, I heard Holly, Wendy, and Jess, each of you kind of say something to this end. So you're noting that it sounds like the diagnosis information is what's put into the record once the clinician validates it. And when we spoke at the data collection side, we talked about how, the screening responses are provided by the patient to begin, and then diagnoses follow if they're assessed appropriately. Do you all store the raw screening results as well?
Yes.
We do as well. We actually have to report on the number of people screened, the screening responses, and screening responses for our Uniform Data System reporting, and then the diagnostic information. Not everybody with the positive screening response will actually have a diagnosis, but that actually appears then on the list of diagnoses associated with the encounter and goes to the problem list. Jess, am I missing anything there?
No, that's accurate.
So we do record both the screening response as well as the diagnosis.
Mhm.
Right, and for example, we've seen some, Z code diagnosis information from Prepare showing up on the encounter records when we receive it from participants. Where are the screeners and maybe even the intervention or goals information stored? Is that in a document format, or is that also stored discretely in your systems?
For us, it's both. It's stored in the document itself and in a flow sheet. Sounds similar to Maine Health.
Thank you.
I will add, Chad, so at Maine General, again, this is recently built out and hasn't gone live yet, but, there are a few interventions that we've sort of called out specific in terms of, resources given to the patient. Also some information where connected to Good Shepherd Food Bank and their emergency, food bag program. And so we track if a food bag was given to a patient that screened positive for food insecurity, for example. So there are a few things that are, going to be sort of, radio buttons that are clicked at the time of the visit to sort of track those interventions.
Great.
And is it all, I guess my follow-up to that too is everything tracked in your own systems, or is there any separate process that might not be tracked electronically sort of outside of your health record at all, or is everything able to be put into the systems that you have?
So I'll just kind of start us off. I will say, at Maine General, everything is going to be in the, clinical record, but not all of it's going to be discrete data. So, like when a social worker meets with a patient and, they refer to different agencies, currently that information is just in the body of a note and would not be a discrete field that could be, reportable or shared.
Okay. That makes sense, Wendy.
that would be the same for us as well.
Okay.
When we send the referral to the agency, York County Community Action, and we get the information back from them, the consult note, it's not in discrete field.
Okay.
I would agree for Greater Portland Health as well.
Communication form. Okay. That makes sense. And I know, sorry, do I just want to highlight Robert from PCHC is on the call, Robert Zabaleta. It looks like he's having connection issues. So just wanted to call that out. And certainly Robert too, feel free to add anything into the chat. I think last time with Misha, she also was having some connectivity issues. So she put in some answers in the chat too as well. So certainly feel free to jump in if you want to. So I just wanted to highlight that for the PCHC folks. Is there a question in the chat? Do we have anything that's jumped up before I carry on?
There's a question, but I think it'll be answered here soon. So I think you can keep going, Nicole.
Okay. So I think we kind of talked about the fact that there is some discrete and non-discrete ways that folks are going about storing it. Sounds like in particular, I guess maybe to clarify around the referral aspect of things, and maybe just to confirm what I'm thinking or what I'm kind of hearing based upon the previous answers, was that if particular, if somebody scored, a positive result or had a positive result based upon a questionnaire and a referral was made either within your own systems or even outside of your own systems, that a lot of that sort of communication or tracking happens in sort of that non-discrete forms of notes between staff or outside folks. Is that kind of the gist of what I'm seeing? Yeah. Okay. So that the encounters themselves will sometimes have a diagnosis attached to it. But that mostly that other types of communication are having in sort of that note form. Any other type of documentation that's happening that sort of tracks any positive response or referral that's made?
I know for Maine Health, we do have some discrete collection of interventions as well, either with flow sheet data or making referrals within the health record. I think part of the challenge may be like the closure of the loop. So if you refer to an outside organization, did they actually complete that referral and like the follow-up of that?
Okay. Makes sense.
I have a follow-up, Nicole.
Yeah.
So for the screeners, diagnoses, interventions, goals that are being collected or reviewed as part of like the prepare assessment, for example, are you all coding them using the industry standard vocabularies like SNOMED, LOINC, ICD provide values that you can attribute back to the responses, or are the raw responses being collected and being stored instead? I'm just curious how much standardization or transformation occurs at the coding level for the responses and follow-up actions that are being had by the providers. I don't know if folks have experience there that they could share.
Our referrals all have an ICD-10 code associated, and as well as notes from the provider.
And it sounds like, Marty, at least with NextGen, their digital formats are kind of helping to standardize that without too much manual intervention. Is that right?
Yep.
Yeah, okay.
And just to add to that, if it gets added to the patient's problem list, the SNOMED code is linked, but if it's just living in the patient's diagnosis history, it's not converted to a SNOMED code.
Yeah, okay.
Thanks, Jess.
Another question. So Anne, you mentioned you're keeping track through flow sheets, perhaps of the history of the different information that's being collected for screeners, diagnoses, et cetera, for your patients. I'm wondering if others are also keeping the history, or if it's kind of looking at the snapshot in time as the most relevant information, or if there's any trending that's occurring otherwise.
I don't think we know that yet, because we're just in the real infancy stages of rolling this out. And I think until we roll it out and have a little time to, be doing a lot of this, that we really don't know yet how this is all going to play out. It's going to be tweaked along the way, I am sure.
Yeah, that makes sense. That makes sense. I guess maybe to follow up on Chad's, do folks have the capacity to be able to do that, or to have a system in place where you can capture this with the hope that over time, you'll be able to see any trends? Maybe something folks haven't thought of yet.
In the current version that we're in, we do have a prepare flow sheet. So you can see the answers and responses over time.
Okay.
So in the current version, we can see that.
Okay.
So, theoretically, if, for at least in our systems, if the data is there discreetly, we should be able to put some kind of a, reporting front end on the back of that in order to be able to do that over time. That should certainly be possible. Just it's not built today, however.
Okay. Thanks, Matt. All right. So one of the next questions that I was certainly interested in, I know we kind of touched upon it a little bit in the previous deep dive, but what we're wondering is there in the systems that you folks already have in place now, is there a process to which you might be flagging certain sensitive data? I know we had talked a little bit about this before, but is there and obviously when we're talking about social health data, everybody feels a certain way about it, and so some people might consider something sensitive at their organization but may not be sensitive to somebody else. But just kind of wondering if there is mechanisms in place that would say this particular social health piece of information, whether that's I'll use the example of somebody being experiencing domestic violence, might be flagged so that it's not shareable information, or that folks either internally wouldn't be able to see it, or folks, if you're sharing that data externally, folks wouldn't be able to see that. And so I didn't know if that exists at all at your organizations, and what that might look like. If it is something, what does that look like?
SOGI data goes into the confidential social history section, which is more protected than other health information in the EHR. The SOGI data, though, it's another data field that we report to our funder on, so we capture it in the EHR in the practice management system as well. And Jess, I'm not what's the level of security there?
We don't have it locked down. Yeah.
And then the prepare tool, the social determinants of health, only appears in the EHR.
Okay.
And again, I'm not sure about the level of security there. the diagnostic code information would carry forward whenever, as the super bill is generated. So that would go to the payer.
Okay.
That would be the same for Greater Portland Health. And I think when you're talking about the EHR, that really gets into patient employees access, what they have available for access on whether it's locked down to them or not. Currently, we don't have it locked down.
Okay. In regards to the fact, like any staff member at Greater Portland Health could have access to varying levels of information. Okay.
It is in the works. We are reviewing that to be able to do that. But currently, and anything that's collected in PM, of course, that's not locked down either, because that's on the demographic side. So.
Okay. And anything that you would share with anybody externally, is there any process in place for that, or any example where something might not be shared?
Not that I'm aware of. And we probably haven't crossed that bridge yet, especially with the prepare stuff, because we haven't started doing it. But not that I'm aware of, no.
Okay.
Holly, is the conversation that you all are having about locking down maybe some of the data, is that at like a per data element level, like some data elements are more sensitive than others, or is it like at a staff role level?
It's more at a staff role level, and just ensuring that we are protecting the integrity of the system through what they have for access.
Nicole, I would add at Maine General, I know that the conversation occurred around, to your point, the domestic violence question, because there was concern about if a patient responded positively and that information, with the information blocking rule went to the portal and, then was accessible to a parent, for instance, of a child, concerns about that. And so there have been conversations about it and about whether or not we could sort of exclude that from information shared to the portal. I don't know what the final workflow will be, but it did come up in conversation because it is a concern.
Yeah. No, that's good to know. And I know, and that's a great example too, of even if it hasn't, just, interested if folks are talking about it, is good to know. And that is a good example too, when you kind of think about varying levels. And I know we kind of had a conversation a little bit about minors and gathering the data. But I think it's important too to kind of think about what's also shared. So once you do collect it and how it's shared to others. But Matt, I don't want to cut you off if you wanted to share something as well.
I was going to just chime in with there are in a couple of EHRs, there are certain notes that are specifically configured for that purpose, like so that clinicians do have an opportunity to say, okay, there are good clinical safety reasons why this content maybe shouldn't go outbound, and then that can be blocked at the note level for the situation that Wendy was just talking about.
Oh, okay, great. So it's up to could be up to the clinician or whoever is treating that individual to determine whether or not to share that information.
Right, and that's more specific to info blocking, because there was a lot of concern there. It's like we have to share the data, but then clinicians, rightfully we're feeling, well, what about these very specific situations where it's not appropriate? So that's sort of where we landed.
Okay. Yeah, that's great to know.
I'll chime in because we got a question that's similar to this, and Wendy, Matt, or others, you may want to add to it. So question is, what are the provisions for confidentiality for teens on these data elements? For example, can parents access these data elements independently of the teen? So it sounds like there's some amount of maybe you don't show sensitive data elements when you don't want it to get into the hands of parents when you know it's a confidential thing for the teen. But I didn't know if there was anything further anyone would want to say to that particular question.
Yeah, as far as like the note itself, that's what you just described was kind of the path. There's some other things too that you can configure through the portal, whether or not there's a proxy account for the patient. There's different scenarios that comes in, but from a note perspective, yeah, what I would describe would be appropriate in that scenario too.
Hi, this is Anne at Maine Med. I know for ages like 13 and up, they're collecting information on like alcohol and tobacco use. And they do so like privately with the patient.
Makes sense. Yeah.
Really complicated question. We have confidential modifiers that we can add with the patient's request, so that the procedure, the bill doesn't go out to a commercial payer in order to prevent an explanation of benefits from showing that the teen is getting contraceptive services and so on. So we were able to do that. We understand that Maine Care does not actually send explanations of benefit statements, so we're less concerned about patients with Maine Care coverage on that front. We put any pediatric information out to the portal. It only begins at age 18. In order to protect privacy for the teen patients. And what else?
Yeah, we do the same with the confidential modifier for encounters. However, we do still mark Maine Care ones confidential, but we still bill Maine Care. But we at least mark the encounter confidential in the event that, something needs to go somewheres, and so people know that it's confidential. I do think it's a limitation, though, of some systems that I believe, and Anne can correct me if I'm wrong, with Epic, you can restrict access to a patient, and you have to, I forget what it's called, break the glass to be able to access that patient. And you better have a good reason for breaking the glass. So I think that that's a limitation of NextGen, because we've asked about something like that. And we asked about it in the context of being able to protect employees that are patients. But that is a limitation for some systems, I believe.
That's a good point. And hi, Lacey. Just to catch you up. So we were just kind of talking, and I don't know if PCHC for your encounters, and in regards to maybe some more sensitive topics that might be gathered, whether you're doing a prepare or whatever screening that you're doing, if PCHC flags anything as sensitive that shouldn't be either shared with other providers or shared to a patient portal, or if there's anything, any process that you have in place around that, or anything that you deem sort of sensitive and non-shareable.
All right, I'm going to try to talk my best, but I don't have the best of voice here. So forgive me.
That's okay.
So yes, we do, especially now with the open notes policy that went into place, and all of the notes being able to go to the portal for the patients to have access. If we do feel that a note is something that is going to cause, harm or detriment to the patient seeing that, then we can flag that to mark that confidential on our end, so it won't be able to go to the portal. I'm not sure about the piece about it going to HealthInfoNet still. I'm not sure if that affects it on that end, but for as far as the patient's access, we had some concerns with, things that we might be putting in their records as far as adult protective service referrals, DHHS, child CPS referrals, things like that, and cases that we might be involved in. So we do have the opportunity to be able to hide those if we need to.
Okay. Is there anything on I think one of the other things we were kind of talking about too is staff access, and certain things that certain staff might have access to, or does all staff have access to the entire patient record within PCHC, within Athena?
It's a good question. I guess I don't know the answer to that 100%. I mean, I know that we have, some safeguards in place as far as if it's a chart that may be an employee chart or somebody that you shouldn't be accessing, that it does give kind of a safety flag, and it'll flag HR to look at those things. As far as patient access, I think that we do have, different settings for like our patient service representatives on the secretarial level than we do for our clinical staff. So I assume that there's different levels of what they can see and access.
Okay.
The prepare tool, I'm not aware of that being hidden. I mean, it is a social determinant of health screening. So
Yep.
if we're doing it and it's part of our EMR record, then it should be going in with our records to HealthInfoNet at this time.
Okay. Yeah, no, that's great.
And we are trying to use that as much as possible. For the prepare, we've definitely increased on our use over the last year. So we started with mainly doing it within our care management department and having our transitions of care teams that are seeing the patients in the homes after their hospitalization or after their discharge. So that's where we started with it, capturing that information, and then we rolled it out to our entire care management team. And then we went the next level and rolled it out to our behavioral health team. And now we do have some MAs in the practices that are using the prepare tool as part of pre-visit planning as well.
Oh, wow. Great.
So,
That's awesome. Thank you. And we heard about your kiosks too last week. That was
Yeah.
interesting to hear about. So that's great.
Definitely.
Yeah. Awesome. Thanks, Lacey. Chad, is there any, I was just gonna ask.
Yeah, I got a question. And I think in so many ways it's been answered, but just to confirm, the question is, have your organizations experienced barriers in storing any of the data collected through an assessment because of some organizational policy or preference? Or has your organizations been open to storing what's collected, and maybe the limitations reside on the technical side if there are any? So just curious if there are any thoughts to that question before we move on.
Our challenges have mostly been technical. We think we've got a report all mapped, and then you run it and it stops in November of 2021. It's I think our policies are pretty appropriate.
And Marty, I think maybe to add to that, it sounds like from the last conversation we had, some of your organizations, it's not you're narrowing or focusing your scope of what types of data you're collecting based on what's considered a priority. So maybe just looking at food security or housing stability in the prepared responses rather than the whole gamut. And so is that maybe where organizational policy is restricting the types of responses collected, not in a bad way, but just maybe in a prioritized way?
No, we're asking all the questions and capturing all the responses. We're prioritizing interventions that address food, housing, history of incarceration. But again, as far as reporting is concerned and tracking information goes, something went wrong with our eye-to-eye population health utility mapping, and our UDS report is due today. We had to do some fast pedaling to get our SDOH data together for that report. Again, it's more technical than policy problems here.
Good luck with your UDS data. We were fast pedaling over the weekend.
Good luck to you, Holly.
Do others share Marty's experience where most of the limitations are technical in nature, less organizational?
I would agree.
Yeah.
Yes, I would agree as well. We do a lot of adjusting to the reports as we go.
And I would say at Maine Health, I know Epic ended up kind of changing the way they collect SDOH information to make it more flow sheet based, to kind of be able to report out on it more easily. So that was a recent change with that data.
I would just add for Maine General, not that there's been sort of policy concerns that we've really run into. I think, what our biggest roadblock was in terms of just getting this off the ground was concerns by our medical staff saying, if we start asking patients about all these needs, what do we have enough resources to, then support the patient? And so it's been sort of more cultural, and I think, and I think rightly so. They have raised those concerns. We're asking about housing, and yet, the wait list for housing is absolutely ridiculous. And so it's a hard position, I think, to put, the clinical teams in to ask questions and feel like they don't have enough to offer for support.
Yeah. No, I think that makes sense, Wendy, for sure. And something too, I'm sure we will also talk more about too in our next deep dive. But yeah, I can definitely see that, and it has been a concern that we've definitely heard before here too, at HealthInfoNet. Any other questions, Chad, before I move on?
No, none right now.
Okay, so I guess sort of the last thing to kind of think about before maybe we move into a little bit more in regards to the SOGI data. Is the social health information made available for exchange beyond your own system? So I know in thinking too about folks and what they're sharing with us at HealthInfoNet, but even beyond us at HealthInfoNet, are you sharing this information with folks, whether it's happening at time of referral, and is there a process in place with the information that you're providing to the referral source, or is it not information that's easily I don't want to say exportable, but easily shareable to an organization outside of your own?
I'll just piggyback. I think explanation of the use case will be in the next deep dive when we get into all about how that data is used by other partners. But I think the question is really a technical one. Can it get out of your system more generally? So just wanted to add that.
Yes, thanks, Chad.
So for me, I can go first. So technically, yeah, there's no limitation there. If the content is built in either our EHRs, that those documents can be built to flow either through HL7 or through some kind of document export or what have you. So there's multiple ways for that discrete data to get out the door. It's just a matter of building out that content and then configuring it to go outbound.
That's great.
At Maine Health, we are sharing information with HIN, including SOGI data like sex assigned at birth, gender identity and sexual orientation information. And then with other like healthcare organizations, we are using Care Everywhere, which is like if other organizations are also on Epic, they can view that data. And then we also share information via Care Quality, the national ONC organization. And then in the future, I know we're looking to kind of share the interventions and referrals that will be provided for any SDOH like risk areas. So it's a future state.
Yeah. That's great. Thanks, Anne. Any others? Is there anything with NextGen, like does NextGen allow you the capability to be able to share things, or is that also a challenge?
NextGen has its challenges. I don't think this is one of them. We also participate in Care Quality, moving information in both directions. We upload diagnostic information to HealthInfoNet for sure. I'm not sure about the screening tool responses. Jess, do you know?
No, not the screening tool responses to HealthInfoNet. Yeah.
So I guess my next question is to kind of take a second and maybe for folks, for our presenters too, obviously we've given our attendees the ability to sort of put questions into the chat. But maybe sort of taking a step back, since we have technical folks on the call for our presenters, but if there's any questions that maybe you have for each other, or things that you're looking to pick someone's brain about, things that maybe they've tried or thinking about trying, and just giving you the opportunity to do that.
When I think about the SDOH information, again, I'm thinking in a patient mode. So, you know, let's say I go to Greater Portland Health, they ask me the questions. Then they refer me to a Maine Health provider. Am I going to get asked them again? Especially if we don't share the info with HealthInfoNet, am I going to get asked those again? So, because to me as a patient, I don't want to be answering these everywhere as I might go in the state of Maine, you know, every time. So I think that's a big, maybe overarching question for all organizations. Are we all going to be sharing this information with HealthInfoNet that would alleviate hopefully some of that? But it's just a thought I had.
That's great, Holly. That's a really good question. A really good thought too, question and thought.
I mean, yeah, you know, because of the nature of this information is so sensitive, you know, if you are asking it time and time and time again at different, you know, location, or, you know, different hospitals or whatever it is, you know, I think as a patient, I'm not sure I would be. So,
yeah.
I appreciate that question, Holly. And I think that, you know, to sort of kind of tag on to that, you know, I know at Maine General, our workflow is really focused on primary care and sort of, you know, an annual screening at your primary care office. You know, we don't have our specialty, you know, offices sort of teed up. And I just wonder if others, you know, you mentioned Maine Health, for example, you know, we certainly, you know, use a lot of Maine Health specialists. You know, are those specialists going to be also doing the screening for social determinants of health, or is it a primary care focus at Maine Health? I don't know if Anne, you want to speak to that?
My role is focused mostly on the inpatient. So I think primary care is trying to be kind of the driver of that SDOH data collection. But I think depending on like the setting, so in the emergency room, you may be collecting like alcohol and you know, nicotine use or whatever is relevant to like the setting. So I think how frequently you may assess and collect the data may also vary depending on the setting you're in as well. But I think it's a good point. Are we sharing that data and asking multiple times?
And it seems it's a great question, and that's selfishly for us. I think that's why we're doing what we do, is to kind of connect the dots, right? And I guess I don't know much from the clinical perspective. Is you know, if Greater Portland Health did the assessment on a patient, they logged the information within HealthInfoNet, all the screeners, diagnoses, interventions, et cetera. And then they go to Maine General the next day. Is from Maine General's perspective, is there a clinical reason to redo the assessment from your organization's perspective? Or if you did see the information in a way that's timely, because it's just coming in yesterday from Greater Portland Health, does that, like, is there some liability as well associated with needing to redo the assessment if you see it already being done the day before, for example?
You know, I think in that sort of scenario, it's not really necessarily a liability issue, you know, for this type of information. I do think, however, it's about, you know, what is easily accessible at the point of visit. You know, do we know that, you know, they just, you know, had the screening done? Is it right there, sort of in front of the, you know, the team that, you know, the medical assistants rooming, you know, the patients, for example. I mean, you know, right now, like our process is that screening would start when the patient checks in, you know, in the waiting room, you know, so is that, PSR going to know that the patient was just screened? Likely not. So it is a challenge.
Yeah, that's great, Holly. I think, and Wendy, I think that's a good question to kind of continue to think about as we go through the convening. Right, Nicole, what do you think? Should we throw up a poll to attendees now and use this as the break between SDOH and SOGI?
Sure.
All right, here, let's see. So I am going to do our second poll. Okay, so this is for attendees. Panelists will also see it, but you can't vote. So for attendees, the question is your organization currently storing social health information as discrete data elements within technical systems? So we'll give a couple seconds to respond to this. We heard from the panelists that by and large, yes, screeners, diagnoses, interventions, goals that are collected in their organizations are, but perhaps the responding information, especially around interventions, may be captured in a notes section in a document, which is not discrete. So just take a second and look that over, provide your response if you'd like to, and then we'll end it and show the results. Just a few more seconds here. All right, I haven't seen movement in a second, so I'm going to end the poll. I'm going to share the results. And so we got about 50% of attendees who participated in this, and 69% of those folks are saying yes, they are storing the data discretely in their systems, 23% no, and then 8% are not actively collecting social health information. So that's a good benchmark for us to use going forward when we engage folks. So I'll stop sharing, and Nicole, I think we can move on to the next section here.
Great. So sort of following under the same thought process and just talking about social health and moving towards SOGI. I know some folks may have mentioned it as part of that social health response, but just to get folks to just clarify one more time for me. So if you are collecting any of the sexual orientation or gender identity information, is that stored a part of the general medical information that folks can see within your health records, or is that being stored somewhere separately within the record where some folks may have access to it, some folks may have not?
If I can start us off, at Maine General, we are currently collecting sex at birth and in some cases, gender identity. And those fields are stored within the EMR and actually part of the patient's banner. So would actually be sort of visible to anybody accessing the patient's chart in the EMR. It also adds the patient's preferred name.
Okay, great. Thanks, Wendy.
And this is Anne with Maine Health. We are collecting it within the health record, and it is visible within the chart. I know in terms of like registration only has limited fields for data collection, so they may not get like the full view of all the SOGI information, like organ inventory type of things. Yeah, but it is visible, so people are aware of any SOGI information, but again, dependent on the role.
Sure. No, that makes sense. Thanks, Anne.
Same here. Practice management, it's part of the banner. Medical record system, it's confidential social information. So sexual orientation, gender identity, pronouns.
Great. Thanks, Marty.
Same with GPH.
And Lacey, is it all of this within the same record, or I think too, and I'm not sure if Misha answered it last week, but didn't know if you are collecting any of the SOGI data and whom it might be visible to within the record.
Right. That's what I was going to say. I missed last time's conversation, so I know that was of a question, and we have not heard of this SOGI language yet, so it's definitely something that's new to us. I know we have specific questions in regards to this information on the demographic sheet that they fill out, and it's captured when the patient first comes into the clinic. So it's initially a paper form, and then there are certain information that's required for UDS that our staff enters discreetly. So
Okay.
I believe it's stored all in the same area and that everybody has access to it. I just, some information is entered discreetly and some's not.
Okay. Okay. No, that's great. Thanks, Lacey. Chad, am I missing anything? Any additional questions?
I don't think so.
Sorry,
Yeah.
in chat. Oh, Felicia had said, so Northern Light, birth sex only in Banner right now for them. Okay. All right. Let's see. Trying to think of some of these questions. A lot of them have been previously answered, so I'm just trying to make sure I've covered them all. So bear with me. I guess too around SOGI, is there anything maybe, I know we kind of talked about a little bit of obviously about the flag situation and certainly things that might be more sensitive to others, but as far as the sharing capability of that information, is that information that your organizations would share with a referral source or would share with another organization, or is that a process that you might have in place where you're not sharing those elements of the SOGI data if you're collecting and storing it, I should say?
This is Jess at Nassau. Our SOGI information is shared amongst external sources. So not only does it live in those discrete fields that Marty described, it also lands on our master documents that get sent out.
Okay.
And I believe is on CCDAs.
Okay. Great. Thanks, Jess.
And I would say for Maine General, our information around sexual orientation is typically not a discrete field. It's information that is part of a note conversation between the clinician and the patient. But gender identity, if that field has been completed, it would be part of like the ADT feed, or it would be shared.
Great.
I know with HealthInfoNet, we are sharing like the sex assigned at birth and gender identity and sexual orientation details. And then we do have the Care Everywhere, where we can share EPIC information between those different organizations. And then with the Health Exchange, we are sharing sex assigned at birth, but plan to include sexual orientation and gender identity fields as well in the future.
Yes. I know we've had some of those conversations, so perfect. Great. Thanks, Anne. All right. Is there any questions, again, to sort of put out to the group, or I guess maybe put out a final call out to our attendees if there are any specific questions that you have for our presenters or things that you're thinking about? I think we very efficiently covered a lot of the questions that we had for folks around their data storage and collection methods. So we may be ending this deep dive sooner than we had anticipated, but I do want to make sure and give folks any sort of last opportunities to put out any questions amongst each other, either with social health and or SOGI, but also put a final call out to our attendees. And Chad, let me know if there's something that's been put out there too that I haven't seen.
Yeah, no further discussion questions at this point. If there's no other questions that come up among the presenters, we can do one final poll.
Okay. Anything at all, anything that you might think of in regards to, and if I know, obviously it's always hard putting folks on the spot, putting them on the spot to ask any questions, but if either our presenters and or our attendees too, if you think about something after the fact, we can certainly reach out to our presenters or also take some time to maybe talk about it in our recap for our deep dive number 3 too. If it comes to you after the fact and just want to reach out to us. I'm not seeing any action in the chat either, Chad. So do you want to go ahead and post that poll?
Yep, sounds good. So similar to the social health poll that we did, let's talk about SOGI for attendees. The question is your organization currently storing SOGI info as discrete data elements within technical systems? So I'll just give a few seconds here to let folks respond. All right, and we're going to end the poll. And it's like almost the same as social health, actually. So here, let's share the results. I think we had 67% of folks saying yes, they were storing discretely for social health. We have 69% for SOGI, 23% no, and 8% not currently collecting SOGI. So yeah, seems like they're kind of dual priorities for folks, which is great to see. So we'll stop sharing this.
That is really great. So certainly, I mean, I know we have talked a little bit about this, I think even during our kickoff call, but obviously we recognize everybody, and we highlighted in our recap, but everybody is at different places with this data collection, whether it is social health and or SOGI. So certainly we recognize that and we understand that you know, this is really just an opportunity to get sort of an understanding and see where folks are at, where they might want to go in the future, or to just know where other folks are at too in this process, and how they can take away some lessons learned from that. So I want to highlight that here at the end as well. And like I said, certainly for folks, if something does come to you after the fact, that's totally okay too, and definitely feel free to reach out to us here at HealthInfoNet. And like I said, we can make those connections, we can get the answers, or we can also highlight it in future convenings or even our closing as well. So just something to think about as you're processing all of this information and trying to come to grips with it, depending upon what stage you're at. So this is definitely one of the biggest reasons why we're having these convenings, is we know that it's definitely interesting work, and it has its own set of operational and technical challenges along the way. So just something to think about. And I'm going to pop up just one sort of final slide here before we start to wrap things up, to just show you where we are at here in our convening series. So this was our data storage convening that we did. The next deep dive we're going to be doing in 2 weeks, which is on March 1st, which is very wild to me that we are at that part of the year already. It doesn't seem possible. But March 1st from 12 to 2, and that deep dive is going to be the social health data use cases and actions. So as we've kind of talked about, we're sort of, you know, breaking this up into different sections. And so now really kind of closing the loop per se, which we probably will be talking about closing the loop a lot during that deep dive, but sort of thinking about, okay, you've asked the questions, you've stored the data, now what do you do? And so definitely taking a peek at that, having some discussion around that, where are folks at, where do they want to go, what do they want to do, maybe in a perfect scenario or circumstance, but really just see where folks, you know, what are they doing and where can we go from here once we've collected all of this wonderful data and information. So just a little preview of the next deep dive and convening. So yeah, I guess, like I said, we'll let you out a little bit early, give you some time back. But thank you so much for spending the afternoon with us. Thank you to our wonderful presenters. You are all fabulous for giving us your time. And we'll see you in a couple of weeks.